I'm going to compile all of them, add some color to it, and tell you how pathology helps an ophthalmologist. Okay, let's begin. Anyone with this diagnosis? Okay, one Cadbury for the diagnosis. Dinosaur. Okay, that's what you ophthalmologists think a pathologist to be. Well, it's actually a slide of an endometrium. So, I mean, we pathologists are not dinosaurs. We are very simple guys. But we strike very lethally and help all of you to treat the patient in the right way. Let's see how. This was a 5-year-old child. No Cadbury's for diagnosing this, right? I mean, you have heard this from the master many a times. What's the diagnosis? Very good, retinoblastoma. Now, that's the CT scan. You have these foci of calcification over here. Now, if I tell you that this is a group E retinoblastoma, what would you want to do? What would be your mode of management? You want to enucleate it, right? Very good. Now, this is how an enucleated eyeball looks like. You have the anterior end over here, you have the optic nerve over here. Now, what is the first thing that you would like to sample when you start grossing an eyeball? Any idea? Very good. You slice the resected end of the optic nerve. That's the first thing you do. Then next, what we do is, then we take vertical, oblique or horizontal sections to, so as to include the peripheral callet as well as the central callet. Now this is done based on the location of the tumor. Now how do I know where the tumor is? What test do we do to? Very good. This is how a transillumination test is done. You pass a light to the cornea, and this is how it would look in a normal eye. And this is how it would look if there's a tumor. This area is dark, so I know that the tumor is over here. Then I bisect the eyeball this way, and this is how an eyeball would look from inside. You have a detached retina, the tumor is arising from the retina, and what is this? The greenish colored thing? Yes, you're right. I just heard it. Those are subretinal exudates. Now, previously I mentioned that one should sample the central callet as well as the peripheral callet. How do we do it? This is the central callet. You take a section from the pupil to the optic nerve, and that becomes the central callet. The peripheral callets are sampled like this. Now, why is it important to sample both the callets? Because there may be occasions where the tumor will have high risk factors in the peripheral callet but not in the central callet. So when your pathologist gives you a report of a retinoblastoma with no high risk factors, always ask him if he has sampled the peripheral callet. This is another view showing a retinoblastoma. If you look over here, the tumor is infiltrating the choroid. Here the choroid is intact, but over here the tumor is going inside. Now let's look how colorful retinoblastoma looks like. Now this is a normal retina. You have the choroid over here, that's the sclera. The tumor is arising from the retina. And classical retinoblastoma will have pink and blue areas. Blue areas are areas of viable tumor cells, whereas the pink areas are areas of necrosis. That's another section which shows these pink and blue areas. Okay, now this is a scan from another patient with retinoblastoma. What is this? Very good. Now this is how calcification looks under the microscope. You have these blue flakes. Okay. Yeah. Now these are very classical of retinoblastoma. Can anyone tell me what this is? Very good. These are rosettes. Now what are the type of rosettes that we get in a retinoblastoma? Very good. Flexavintestinor, homerite, pseudo rosettes. Very good. Yeah, all of you know your pathology very well. I don't need to be here. Okay, so what's the difference between flexavintestinor and homerite rosettes? Very good. In flexavintestinor rosettes, you'll have a central lumen, while in a homerite rosette, you'll have the central area filled with what is called neuropil. This is basically cytoplasmic processes. Fine, I tell you that you enucleated an eye, I tell you this is a moderately differentiated retinoblastoma. What are you going to do next? Very good. You would want to know whether there are high risk factors. Now what are the high risk factors? How many of them? 1, 2, 3, Can anyone enlist all the 7 high-risk factors? Okay. High-risk factors include invasion of the optic nerve. You need to know whether the head of the optic nerve is involved, whether the lamina cribrosa is involved, or whether there's involvement of the retrolaminar optic nerve. Then you need to know whether the resected end of optic nerve is involved, because involvement of the resected end makes it T4 according to the latest AJCC staging. Then you need to know whether the choroid is involved, scleral involvement, anterior chamber involvement, that includes involvement of the iris, the ciliary body and the angle, and of course extraocular invasion. Okay, now this is a section of a normal eyeball. This is the optic nerve. This blue band that you see, that's the retina. The pigmented thing is the choroid. Now can anyone tell me where the lamina cribrosa is? Okay. How do you identify lamina cribrosa? Okay, this is the lamina cribrosa. Now the best way, the logical way to identify it is, now if you see the sclera, try to imagine it and join the 2 ends of the sclera. And the line, the imaginary line which passes through the optic nerve, that's where your lamina cribrosa lies. If you want to talk about it histologically, it is the line where the transverse and the longitudinal fibers of the optic nerve meet. So over here, if you see, these are transverse fibers, these are longitudinal fibers. So here's the lamina cribrosa. Now this was one tumor where you see the head is involved. The lamina cribrosa is intact. There is no involvement of the retrolaminar optic nerve. Look at this one. The tumor is going through the lamina cribrosa into the retrolaminar optic nerve. Now when your pathologist tells you that there is involvement of the retrolaminar optic nerve, ask him how much. Now normally a low power field of a microscope is about 2 millimeters. So even if he doesn't have a vernier calipers on his microscope, he can still tell you how many low power fields are involved. This is how involvement of the resected end of optic nerve would look like. You have the tumor over here. That's another resected end. Is this involved or not? No, right? It is? Very good. There is involvement of the meninges, and that still counts as T4. The parenchyma is not involved over here. Okay, this is how choroidal invasion would look like. This is full thickness choroidal invasion. Now what type of choroidal invasions exist? How many types are there? We have 2 types of choroidal invasion, massive and focal. Focal is anything less than 3 millimeters either in width or thickness, and massive is anything more than 3 millimeters. What are these? Ciliary processes. So you have the angle over here, that's the anterior chamber, you have the iris here, and this is the cornea. So in this case, the angle is involved, the ciliary body is involved, you have involvement of the retina, you have the tumor in the anterior, you have involvement of the iris, there's a tumor in the anterior chamber as well as the posterior surface of the cornea. Now that's another high risk factor. Now this is how sclera looks like. You have massive choroidal invasion, and at one point the tumor is getting into the sclera. So this is scleral involvement. Now in this slide, you see tumor on both sides of the sclera. So this is extraocular tumor invasion. Okay, let's get on to the next case. Now we have heard Dr. Prasad and Dr. Swapna speaking a lot about this. Does anyone want to describe this? Okay, say this was a 35-year-old man. What do you see over here? Okay, what do you see over here? What photograph is this? Okay, slit lamp photograph. What do you see over here? Okay, I tell you that he came with history of burning in his eyes. Sorry? Okay. Okay. So do you see infiltrates over here? There are. What kind of infiltrates? Full thickness, anterior, posterior? Okay. Now this was a corneal. Okay. What would be your differential diagnosis? Sorry? Acanthamoeba. Okay, that's a good differential. Anything else that you would want to think of? Microsporidia, that's another good differential. Okay, So a PK was done. Now this is what the corneal button showed. And this is the corneal epithelium, that's the Bowman's. This is the posterior where you see the endothelium. And this was a suture which was left from the previous PK. So if you see over here, the infiltrate is mainly posterior. The anterior stroma appears clear. Now that's another high mag view which shows infiltrates posteriorly. Now what stain is this? Which stain appears green? Jimsa. Sorry? Can you be a little loud, please? What stain? Okay, it's okay, be a little loud. That's okay if you're wrong. What is GMS? Gomery's methanamine silver. What's the other name for this stain? It's called Grokert stain. So Grokert stain appears green in color. The background appears green. And can you see these blackish blue bodies? What do you think these are? Okay, now this is the smear. What are these? That's a normal epithelial cell, and you have these bodies lining this cell. And this is another GMS stain which shows these bodies. No? Okay, which organisms are GMS positive? Fungi, very good. Acanthamoeba, very good. Now which is the third one? And that's this. No? Mycosporidia. And what would you do to confirm Mycosporidia? Okay, let's not go into microbiology, histopathology. What stain would you do? You do a 1% Zn stain. Now for tuberculosis, you use 20% Zn stain, but for Mycosporidia and nocardia, you use a 1% Zn stain. And this is how Mycosporidia look like on a 1% Zn stain. That's the high mag view. Okay, they appear acid fast. Okay, that's a Cadbury question. Now people who are at eye focus, please don't answer. What is this? Look at the clinical picture first. Does this look, okay, what does this look like? Calcium. Are these infiltrates? Are these deposits? These are deposits. Okay, what type of deposits? No, how do you describe the pattern? Are they streak-like? Do they look streak-like? They look more granular, right? So the clinical diagnosis was a granular corneal dystrophy. Now where are the deposits in granular corneal dystrophy seen? Which part of cornea? Anterior stroma. So that's where you see these deposits. You have these deposits mainly in the Bowman's membrane and the anterior stromal region. And what stain do you do to Mason's trichrome? Very good. And so that's a positive Mason's trichrome stain, confirming the diagnosis for granular corneal dystrophy. What stain do you do for lattice corneal dystrophy? No, amyloid is the material. Congruent. And what do you see? Birefringence under? Very good. And what stain do you do for macular corneal dystrophy? Alcian blue. Very good. Okay, now this was a 35-year-old male who had diminished vision for past 3 months. B-scan showed a mass in the choroidal region, moderate to high internal reflectivity. What would be a diagnosis? Choroidal melanoma. Now with this size of a melanoma, what would be a treatment of choice? Would you want to do a brachytherapy? Or would you want to enucleate it? It's a large melanoma, so you enucleate it. Okay, but again, before I gross the specimen, I do a transillumination test. Can you see this pigmented tumor over here? That's how a melanoma would look like. This is the gross cut section of the eyeball. Can you see this tumor? That's the melanoma. You have the detached retina and subretinal exudates over here. That's again a mushroom-shaped melanoma. Why does a melanoma appear mushroom-shaped? Homework. Okay, now this is the whole mount of the eyeball, which again shows this mushroom-shaped melanoma. That's the lens, this is the optic nerve. This is how it looked like under the microscope. Okay, when I give a diagnosis of melanoma, or your pathologist gives you a diagnosis of melanoma, what you have to see is that the maximum thickness and the width of a melanoma, because that alters your AJCC staging. You have to know the type of cell type in a melanoma. What are the different cell types in a melanoma? 4 cell types. And what classification is it called? Callender's classification. So you have spindle A type, you have spindle B type, you have a mixed type, and you have an epithelioid type. Okay, now this. Fine. Now, what do you think this is? This is a cut section of an eyeball. You have the optic nerve over here. That's the cornea. So what would this region be? What region is this? Is it choroid? It's a ciliary body region. Now what type of mass do you see over here? It's a dome shaped or round solid mass. Pigmented, non-pigmented? It's a non-pigmented mass. So what could it be? It could be a melanotic melanoma. Any other possibility? What is ciliary body made up of? Smooth muscle. So what is the tumor that arises from the smooth muscle? Leiomyoma. So this was a case of a leiomyoma, ciliary body leiomyoma. And this is how a melanotic melanoma looks like. You see the mass is in the choroid, and you have complete retinal detachment, subretinal exudates. Okay, now this was a 33-year-old female who presented with this mass on the lower eyelid. What do you think it is? Chalazion? Okay, what would you want to do? Excise it and throw in the dustbin. Okay, you want to send it to me. Fine. Let's see what I found. That's the epidermis. You have the dermis over here. Can you see this pinkish material deposited? Does it look like keratin? No, it doesn't. Keratin would be over here. This is the dermis. This is the epidermis. So keratin would be above the epidermis, not below the epidermis. So basically this is a acellular pinkish material, which could be, that's the congruent stain. Can you see this positivity? So what is something that is congruent positive? Amyloid. And that's the apple green birefringence which was seen under polarized light. So this was a case of cutaneous amyloidosis. Now amyloidosis is a systemic condition. Now, when we looked into the history of this lady, what we found is that she was infertile. So we did a ultrasound of the pelvis, and we found bilateral ovarian masses. Oophorectomy was done, and this is what it showed. Nodular amyloid deposits, which were again congruent positive, and apple green refringence under polarized light. Okay. Now this was a 6-year-old child who had swelling in the upper eyelid. Let's see. Doctor, okay, say this is for 10 days. 10 days, no fever, nothing, absolutely nothing. Just a mass. You just heard Dr. Santosh speak about CT scan and MRI. So where is the mass located? Superior and anterior, sorry? Okay, superior nasal. So what do you think this could be? Considering the age of the patient, sorry? Idiopathic orbital inflammation. Would that be your first differential? Idiopathic orbital inflammation is always a diagnosis of exclusion. So, pediatric patient with an orbital mass. Sorry? Rhabdomyosarcoma, okay. Anything else? Capillary hemangioma. Would hemangioma be solid? Very good. Lymphoma. Anything else? One more. And that is what it is. Okay. Fine. The first line of investigation, the third differential would be a leukemia, leukemic deposits, or a granulocytic sarcoma. And what would be your first line of investigation? Blood smear. You will want a CBC. Now in this patient, the hemoglobin was 10.2, total count was 5,200, platelet count was 1.1 lakh, and a pretty normal appearing differential count. Peripheral smear was reported normal. Now this was done outside. I did not report it. So now what? Yes, it can. It can. It could be. So what would you want to do? You would want to biopsy. Very good. Now this was another patient. This was a 10-year-old chap who again had this mass, and that's what his CT scan showed. Okay, I'm coming to the diagnosis of the previous one. I have not missed it. What do you think about this one? Again, a pediatric patient. So your differential is again going to be the same, and you would again want to do a peripheral smear with a CBC. Even here, everything was normal except that his hemoglobin was a little on the lower side. Platelet counts were, around the lower borderline mark. This was a 25-year-old chap, same history. 18 days history, rapidly growing mass. The CT scan showed an orbital mass. That's another view. Peripheral smear again reported normal, hemoglobin 11.2. Platelet count was a little lower, and differential count showed a mild lymphocytosis. I don't know if it is really significant. Now in all these patients, a biopsy was performed as you suggested. In this patient, it showed a very highly malignant round cell tumor, and it had this appearance. What is this? Green. What is green? Chloroma. Why does it appear green? Okay, chloroma is what? What is a chloroma? It is a tumor of what type of cells? Leukemia. Basically myeloid cells. And myeloid cells contain myeloperoxidase. So when it exposes itself to sunlight, that's what you get, a green color. Now this is another patient, the other patient, same type of cell morphology. And the third one, again the same type of morphology. So all three of them had a granulocytic sarcoma. So we did, what is the next line of management that you would want to go on? Very good, bone marrow biopsy. But before that, I thought I'll confirm it with immunohistochemistry. So all these tumors were positive for myeloperoxidase and CD117, both of which are markers for myeloid cells. Then a bone marrow was done. This is what the bone marrow showed. Can you see these cells? These are all blast cells. So it was a case of AML. And what is characteristic of myeloid blast that you see on a bone marrow? One very characteristic thing. OR rods, very good. And this is how OR rods look like. Can you see these crystal-like things? So these are OR rods. However, when I went back and did a peripheral smear myself, I found that in all the three patients, the peripheral smear showed blasts, and it was missed by laboratories. So when you see any abnormality in a CBC, ask the pathologist to repeat a peripheral smear. Okay. Now this was a 12-year-old girl who had gradual diminution of vision since early childhood. These are the slit lamp findings. Does anyone want to tell me how it's normal, abnormal? Okay. Arbometry was not possible. Okay. Now this is what Dr. Himanshu spoke about in the morning. Normal, abnormal? It's normal, right? It's normal. Now what is this? Anterior lenticonus. Now what are the conditions that anterior lenticonus is associated with? Alports. Everyone knows this. Tell me the other two. Sorry? No. What is Waardenburg syndrome? So does it have lenticonus? Is lenticonus associated? Yes, it is. And what is the third one? Spina bifida. So these are the three conditions with which anterior lenticonus is associated. So when you want to diagnose Alport syndrome, what is the first thing that you would want to do? Very good. You would want to do a urine examination. So this is what it showed. A lot of RBCs. So you have microscopic hematuria, and in Alport syndrome, this is what you see. Glomerular basement membrane deposits. Very characteristic of Alport syndrome. Okay. We have 5 minutes. We'll rush through the next. Okay, what is this? 63-year-old lady, lower eyelid mass, fungating, nodular, ulcerative, squamous. Okay. I heard basal, I heard squamous. All three. What would you want to do? Biopsy it. Okay. Now this is what it showed. You had these lobules of tumor cells, central comedonecrosis, and then you had these clear cells, sebaceous. Why do they appear clear? Okay, I know it's fat, but why clear? Fat dissolves during the process of tissue processing in alcohol. That's why these cells appear clear. And now this is how pagetoid spread looks like. The tumor cells get into the epithelium. So when I tell you that you have done an excision biopsy, margins are clear, however there is pagetoid spread, what is the next thing that you would want to do? No, you would do a map biopsy. You would do a conjunctival map biopsy. And this is how what Dr. Santosh does. He takes about 18 tissues, each of which are processed separately, and I give a report on them separately so that he knows where exactly you have a pagetoid spread. Okay. Now, in addition to this, what we do is, have you heard of something called MMR genes? Mismatch repair genes? Okay. Now, which is that syndrome that is associated with? What is the syndrome called? Okay, that's a condition. Hereditary non-polyposis colonic cancer is a condition. Now, that in association with sebaceous gland carcinoma, what is the syndrome? No. Yes, someone just said it. Mutor syndrome. Very good. So in that, what happens is one of these genes is mutated. So DNA repair doesn't happen, and that's what we do. And this was a patient who turned out positive, and we finally found a tumor in the colon. What is this? Cakewalk. No pathology in it. It's an implant. Okay. Okay, now this was a patient who came with redness, diminution of vision, watering, etc., etc. Differential diagnosis? Okay, fungal ulcer. Anything else? Okay, that's how the biopsy looked like. You have full thickness infiltrates. You have a rupture of the Descemet's membrane. The infiltrates are present even in the anterior chamber. You have multinucleate giant cells. What stain is this? GMS. And what are these? Do they look like microsporidia? No. What are these then? Very good, acanthamoeba. And what is this? Calcofluor white. No? This is showing acanthamoeba. Okay, let's skip this. I think. Okay, now this was a 63-year-old female who had a previous excision of the lacrimal gland for a suspected lacrimal gland tumor. Now following that, she had burning sensation and stickiness in her operated eye. Then she landed up about 3 weeks later with a mild proptosis and severe dry eye. There was restriction of ocular movements. What would you want to do? What would you want to do? Without a CT scan? Okay. This is what her CT scan showed. Can you see this? Okay, I'll show you a better picture. Can you see this? Now what? Okay, I was asked to review the previous slides, and it showed dense inflammation and fibrosis. There was no tumor in it, so it was a case of chronic dacryoadenitis. Patient operated with dacryoadenitis now presents with a mass again. Now what? Okay, so what would you want to do? You want to excise it? No. Then directly give radiotherapy? Yes. How do you know that a diagnosis of lymphoma is confirmed? You would want to confirm it.